Hello, everybody. Welcome back to the Incubator Podcast. We are back for an episode of Journal Club. Daphna, how are you?
I'm doing well, buddy. I've got everything pulled up here, trying to keep the computer quiet so we can have a nice, seamless episode.
This episode is going to be released in the podcast, obviously, but also on YouTube. We're trying to do a lot more video stuff for you guys. That being said, we're at this point of the year where we're celebrating the anniversary of the podcast. And so May 4th was the first episode, 2021.
Yeah.
And it's now been 4 years that we've been doing this. It's truly been 4 years. We haven't missed much.
No.
And,
Hardly a week, I think, in 4 years.
And so we will roll out this week on the website our annual giveaway to celebrate the birthday of the podcast. So we've talked about it on this YouTube video, and we will repeat it here. We're going to do the same thing we did last year. It's a very short survey. We take that information. It helps us make the incubator better. And then if you submit the survey, you automatically enter to win one of our many prizes. We have an Apple computer this year.
Mm-hmm.
So that's very exciting. We also have some swag from our shop. We also have tickets to Delphi. We have books. So hopefully, I don't know. We have a big audience. I don't know if everybody's going to get a prize, but at least you should feel like you have a high chance of
We like to give stuff away.
Walking away with something. Yeah. So we are happy about that. So we'll put it on our brand new website on the top banner. It will be one of the featured sort of pages, and then you can go fill out the survey. It will take you 5 minutes, and then you're entered. You don't need to do anything. We used to do a lot of these, like, tweet, you repost, and you hold one hand up and 1 feet down, and then
do a handstand.
Go to that survey. You're done.
Yeah, and we really appreciate when people fill out the survey because we have always made changes.
Comment.
Yeah, we read every single comment. We make changes. We've always made incremental change based on the feedback from the community.
Yeah.
And I mean, as we do this 4th birthday thing, you did a nice job on the video, but it's really in part to everybody who tunes in and listens and engages with us. And we're so grateful for people who've been along for the ride or are joining us now or sharing with a colleague, for sure.
Yeah. Whenever we hear that this works for you all, not that we need to hear that it works for you all, but when we hear that what we're doing actually makes a difference in your day-to-day, like it gives everything we're doing meaning.
For sure.
The meaning that we're hoping for. So that being said, Journal Club doesn't wait for no man or no woman.
All right, you go.
All right. I don't know what to start with.
I know you're very excited about this group of articles.
Yeah. I'm going to start with something that is probably on everybody's mind all the time. And this is a paper that is published in the Journal of Pediatrics, and it's called Furosemide Safety in Preterm Infants at Risk for Bronchopulmonary Dysplasia. First author is Rachel Greenberg. It's a very, very interesting paper. Taking a look at furosemide, Lasix, and we know that Lasix obviously is used in so many units. Half of all preterm infants under 1,000 grams in the NICU get Lasix. So it's always that stat that keeps coming back with every furosemide paper, but it's still like every time blows me away. We still don't have a good idea on how and when to use it. So it's always interesting how our field is. Now, the idea in this paper is the idea of, obviously, is always simple. We try to treat pulmonary edema. We try to improve gas exchange. And for many, there's this belief that can we reduce BPD? Can we reduce the incidence of BPD? Until now, we've only really had small trials, maybe database review, retrospective reports, and there's not a lot of pharmacokinetic data available out there. And the result is what we are encountering: massive variability. Now, this particular study is important because it's going to be the first sort of multicenter randomized placebo-controlled dose-escalating trial of furosemide in this particular population of preterm infants. So I was very interested in reading this paper. It's a phase 2 trial that was conducted between 2015 and 2018 across 17 NICUs in the US. They included babies based on certain eligibility criteria. They had to be less than 29 weeks of gestation at birth. They had to be 7 to 28 days postnatally at randomization, and they had to be on some form of respiratory support, CPAP, high flow, or mechanical ventilation. Their exclusion criteria included like diuretic exposure, electrolyte or renal abnormalities, hemodynamically significant PDA, meconium aspiration, or known diuretic allergies, which, yeah, I've never thought of that before. The intervention is an interesting one. They basically randomized kids in a 3-to-1 ratio furosemide to placebo, and they divided their furosemide group into 3 groups. And so bear with me here. They had the first cohort, which was a low dose. They give them 1 mg per kilo IV every 24 hours. They had a low, and they did also offer Anterol, but the conversion was basically double. So they had this pharmacokinetic assessment that basically determined that if you were using 1 milligram per kilo IV, based on the absorption and so on, it would probably need to be 2 milligrams per kilo Anterol. So every dose will be multiplied by 2. Then they had a cohort number 2, which was a medium dose, and that was 1 mg per kilo IV given every 6 hours. And then they had a cohort 3, which was the planned high dose. And planned is the keyword here because they were supposed to give 2 mg per kilo IV 2 milligrams per kilo IV Q6, or 4 per kilo Q6 enterally. But they never really initiated because there were some safety concerns. So we'll get into that. The infants in the study all received the drug for up to 28 days. And whether it was going to be given IV or oral was left at the discretion of the team. They didn't really influence that decision. They monitored the labs for these babies pretty closely: electrolytes, sodium, potassium, bicarb, BUN, creatinine, and phosphorus. And they checked at least twice weekly following dose escalation, because obviously they started these kids on lower dose and escalated. I say BUN. Do you say bun? You're muted. I've heard people say both.
No,
and
BUN.
The first time I heard bun, I was like, what is that?
What's a bun? BUN.
Yeah. So the primary endpoints were, obviously it's a phase 2 trial, so that was safety measured in the form of adverse events or serious adverse events, but they also had some key outcomes that included death before 36 weeks, moderate to severe BPD or death, electrolyte abnormalities, hearing loss, and then renal complications like nephrocalcinosis or nephrolithiasis. So let's get into some of the results. They ended up having about 82 infants randomized. 62 went into the furosemide groups, and 20 went into the placebo group. 80 completed the study. The median gestational age was 26 weeks. The median birth weight, 798 grams. And the median postnatal age at randomization was 21 days. 93% in the furosemide group reached their max dose. I'm not going to get too much into that, but basically for the kids in the higher dose, they basically did a dose escalation process where they started them on lower doses and then eventually started escalating the dose, checking electrolytes and so on and so forth, making sure that this was well tolerated. So it's important to note that 93% actually reached their max dose. And there was some open label diuretic use in the study, like 24%. So take that as you wish. So in terms of adverse events, surprisingly, even the placebo, there was a lot of reported adverse events, 293, which is which corresponds to 93% of adverse events. I just want to check in my notes if that I didn't, because this is such a high number of infants. So 93% of infants, including 223 adverse events among the infants who received furosemide, so 92%, and they reported 70 adverse events, 95% in the infants who received placebo. So there were adverse events in both groups, but basically the most of them were very mild or moderate. And there were 14 serious adverse events in 20% of infants in the furosemide group and only 11% in the placebo group. Now, of these 14 severe adverse events in the furosemide group, 2 were deemed by the site investigators as at least possibly related to the study drug. So definitely something that to me doesn't seem particularly striking, and speaks a little bit about maybe the safety of furosemide. And we'll talk a little bit more about that. When it comes to some of the secondary endpoints, let's talk about mortality and BPD. On adjusted analysis, they found no significant differences in the combined outcome of BPD or death between the groups, with an odds ratio of 0.97 for cohort 1 um, compared to the placebo, and then an odds ratio of 2.59 for cohort 2 versus placebo. So, yeah. In terms of serum electrolytes, um, obviously they found one or more serum electrolytes adverse events that occurred in 83% of the AD infants, 84% of the cohort in the low dose of Lasix, and 93% of the babies in the cohort with the moderate dose of Lasix. On adjusted analysis, the odds ratio for having any serum electrolyte abnormality was 4.46 in cohort 1 compared to placebo, and 7.89 for cohort 2, again the medium dose versus placebo. Another interesting outcome is hearing loss. They found that hearing loss prior to discharge was seen in 14% of the furosemide treated infants and in 22% of the placebo treated infants. And so, as you can suspect, on the adjusted analysis, they found no difference in furosemide potentially increasing the risk of hearing loss, which was kind of surprising because we know that ototoxicity is something that we always learn about furosemide. So could it not have an impact in babies this small? Maybe. And the authors do talk about that in the discussion. In terms of nephrocalcinosis and nephrolithiasis, nephrocalcinosis was diagnosed on renal ultrasound, and it was seen in 23% of the furosemide treated group compared to 29% in the placebo. So again, not something that was found to be statistically significant. The nephrolithiasis, also no significant difference, but the numbers were very, very small in that case. So they're having some issues, obviously, reporting on that and making it sort of more of a generalizable result. In terms of BPD or death risk, which is also like kind of an innovative thing that this study did, where they didn't just look at the outcome of BPD, as we mentioned earlier, but they also looked at the potential trajectory. So using the BPD calculator that is available on the Neonatal Research Network website. So if you go on the Neonatal Research Network website, you can actually go to the tools and you can get the outcomes estimator for your prenatal consult, but you can also get the BPD risk calculator. And so the BPD or death risk, because obviously death is one of the outcomes that is measured in the BPD calculator, decreased from baseline to week 4, regardless of the study drug. And on the adjusted linear regression analysis, the treatment estimate for cohort 1 versus placebo was minus 2.7, and for cohort 2, it was minus 1.34. The overall treatment effect was not found to be significant, with a p-value of about 0.6. Now, in terms of the third dose, the third cohort with the very high dose, now the trial was basically terminated after an unmasked review of cohort 1 and 2 interim safety and efficacy data. The FDA concluded that the risk-benefit assessment for the third high-dose group was not favorable and directed the study team to remove the high-dose cohort, which was what they did. So, in summary, this trial of preemies shows that Lasix furosemide administration at doses of 1 through 4 mg per kilo per day for 28 days was not associated with an increased incidence of adverse events. It was not associated with an increase in hearing loss and nephrocalcinosis or nephrolithiasis, and future larger trials are needed to better define the optimal use of Lasix in preterm infants with developing BPD. Now, these trials will likely need to include management of electrolyte as part of the trial design, with amelioration of the electrolyte abnormalities. These trials may be able to safely administer higher doses of furosemide to determine the risk and benefits of prevention of BPD. And I think that this is obviously something that in retrospect feels a little bit obvious, that, yeah, like Lasix is going to mess up your electrolytes, but obviously that cannot be sufficient to exit the trial, because then you're going to have issues again trying to test these much higher doses. So I thought this was interesting. I don't think it changes very much. I'm not a big advocate for Lasix in general, but it's kind of data that needs to be reviewed if you're a neonatologist. It is, after all, a phase 2 randomized trial. Like, it's a multicenter trial. Like, it's important data. Should be familiar with that.
Well, and I mean, this really kind of there was a big pendulum swing on diuretics in general, right? And so revisiting this is interesting. It's a lot of Lasix, right? So here we are, like, should I do a 3-day course, a 5-day course? Can the baby get the one dose, and they're doing 28 days. So it was interesting, to say the least. I was also quite impressed by how much nephrocalcinosis there was in the placebo group.
Yeah, exactly. And again, it may be showing that, I think that's always the big fear, that we don't know the effectiveness of Lasix, but what about the side effects? But to me, to see
Sure.
that hearing loss was not as prevalent as I would have expected. Neither are kidney stones. I think that's quite good. We've spoken to Nick Bammett from
He has
CHOP
very strong feelings about
at Hot Topics, about specifically that he had published some work with using the pediatrics database on Lasix, again showing that, number one, Lasix remains one of the most used medications in the NICU. So we should have a conversation about Lasix, and but again, advocating for what you were saying, that it probably has a place, but it doesn't have a place for an indefinite sort of type of treatment where kids can be on it for weeks and weeks and weeks with no endpoint in sight. So, interesting data.
Yeah, very interesting. All right, I have one for you. I have some international papers this week. You put this one into the folder: 7-day versus 14-day antibiotic course for culture-proven neonatal sepsis, a multicenter randomized non-inferiority trial in a low and middle income country. So this is coming from India. And basically, the study was looking at, is 7 days non-inferior to a 14-day course, even in the face of culture-proven infection. So this was a multi-center randomized non-inferiority trial, 1-to-1 allocation ratio, and the outcome assessment was felt to be blinded. This is part of kind of an ongoing study. This is like a sub study. So, but they enrolled neonates that were 0 to 28 days old with a birth weight of greater than or equal to 1,000 grams. So not the smallest group of babies, but still quite small, and suspected sepsis. So antibiotics were initiated by a neonatologist after sending a blood culture. So this is a group of babies that were screened, but inclusion criteria required a positive bacterial blood culture, receipt of at least 7 days of quote unquote appropriate antibiotics, so the pathogen was unambiguously sensitive to, and clinical remission of signs of sepsis by day 5 of this appropriate antibiotics. So then on day 7, so the baby had to be basically improved, well appearing, and have had these 7 days of antibiotics. So then on day 7, you hear the dog. She's being very annoying.
Actually, she's not bothering me today.
Okay.
So I can hear her. We have good microphones now.
She's only bothering me. So basically on day 7, then they were randomly assigned to either receive the 7 days, which
So there would
was
be
the
like no further
intervention to be
treatment.
done. Yeah, to be done at 7 days, or 7 more days for a total of 14 days, which was the comparison arm for antibiotics. They had some exclusion criteria. So the growth of contaminants, they excluded Staph aureus, interestingly, or fungi. If there was ambiguous in vivo antibiotic sensitivity, infections that were felt to necessitate more than 14 days of antibiotics, like meningitis or life-threatening malformations. A lumbar puncture was performed on all participants. Cons were considered, or coagulase negative staph was considered contaminant if they grew after 48 hours of incubation, or if repeat cultures were sterile despite resistance to the empiric antibiotics chosen. Okay. So I told you they randomized the babies, but they also randomized, they stratified the randomization by center and birth weight categories. So 1,000 to 1,500, 1,501 to 2,000 grams, and then greater than 2,000 grams. They felt that weight would be potentially an important determinant of host immune response. Okay, they enrolled the babies and they monitored them weekly for at least 35 days post-randomization. So the outcome variable they were looking for primarily was this composite of a definitive or probable relapse within 21 days after antibiotic completion. So did we treat it or did we only partially treat it and it came back? A definitive relapse was an episode of sepsis caused by the same species as the original infection with an identical antibiogram. And a probable relapse was adjudicated based on clinical signs and laboratory parameters with a sterile blood culture. So they had a definite relapse, or if the baby had these new signs and symptoms, but they couldn't prove the same species after treatment. Okay. Sorry. I didn't know what I wanted to say there. Okay, I think that is it. All right. I think we'll have to get into it. So they recruited participants from February 2019 to December 2022. So they actually performed an interim analysis after 261 patients were enrolled, 126 in the 7-day and 135 in the 14-day groups had completed their follow-up. So actually at that time, after the interim analysis, the Data Safety Monitoring Board recommended this trial termination as they felt the non-inferiority was demonstrated using two-sided 99.5% confidence intervals. So about the study, the baseline characteristics were pretty similar between the two groups. In the 14-day arm, 10 participants clinically deteriorated during the 8th to 14th day of antibiotics. So they were on the extended course of antibiotics, including 2 with a new culture-positive sepsis episodes. 1 died and 1 was transferred. 6 participants were excluded from the follow-up analysis, 1 from the 7-day arm because that baby was enrolled despite probable meningitis. So that was one of the exclusion criteria, and 5 from the 14-day arm because 4 were lost to follow-up and 1 had an incomplete antibiotic course. In the 14-day group, 1 infant required ventilation and inotropic support. 1 required a packed red blood cell transfusion. None in the 7-day group required ventilation, inotropes, or blood products after randomization. 2 participants in the 7-day arm and 6 in the 14-day arm experienced the primary outcome with a risk difference of -3%. Sorry. And the confidence intervals, I didn't tell you the confidence intervals, but they cross 0. So as the upper bound of the confidence interval was well beyond below the non-inferiority margin, again, there was a recommendation to stop the trial. In the modified intention to treat analysis, they included 3 additional participants whose outcomes were known, 1 lost to follow, but later identified, 1 whose 14-day course was incomplete, and the 1 enrolled despite meningitis. 3 others were excluded from that analysis because then they were lost to follow-up and could not be tracked. But the risk differences for the primary and secondary outcomes supported the non-inferiority of the 7-day antibiotic course. They did a sensitivity analysis for many outcomes. I will list them for you. That was the definite or probable relapse by 21 days, mortality or definite or probable relapse or secondary sepsis by 21 days, definite or probable relapse by 28 days, mortality or definite or probable relapse or secondary sepsis by 28 days, definite or probable relapse by 28 days. They used those post-completion and post-randomization. So they had duplicate sets here. But basically, all of those sensitivity analyses favored the non-inferiority of the 7-day course. The median durations of secondary outcomes were significantly lower in the 7-day arm, and adverse events did not differ significantly between the 2 groups. So I think this is interesting. We're always talking about antibiotic exposure, and I think that's true in a lot of facets of medicine. We don't know how much antibiotic is enough, and we are reducing antibiotic courses for lots of things. It would be nice if we could use shorter courses in our small babies. I'm not saying people should change what they're doing. I'm just saying I'm glad people are looking into it. Because
Yeah, I
hopefully
think
we'll get to a place where we can use shorter courses.
I agree, and I think that it's going to come from
Yeah.
low and middle income countries where
Mm.
resources are definitely thought of a
Mhm.
little bit more carefully. So um, maybe they will be able to bring about the reassurance that a shorter course, even in culture proven sepsis,
Yeah.
can actually be valuable. So yeah, definitely interesting. Okay, I am next. I have definitely two papers that I want to bring. Maybe I'll leave this fun one for last. The other one that I wanted to review is a paper that was published in the Archives of Disease in Childhood called Intermittent Sigh Breaths During High Frequency Oscillatory Ventilation in Preterm Infants, a randomized crossover study. So I feel like it's an ongoing question. I don't know where some of our listeners are practicing, but sigh breaths on high frequency is always a point of discussion. Should we go up? Should we go down? Should we even have it in the
Even in
first
our
place?
own unit.
Oh my God, yes. And so we know that the reason it's a topic of conversation is because ventilator induced lung injury is always a concern. And one of the goals with high frequency is to maintain adequate and expiratory lung volume while minimizing barotrauma and value trauma. Now, the sigh breaths are kind of widespread, and it's and there's it's been used obviously for patients who are on high frequency jet ventilation, but there's a growing interest in combining brief conventional sigh breaths for high frequency oscillatory ventilation to facilitate lung recruitment without interrupting the high frequency pattern. And this paper is actually here to test this idea in the form of a randomized clinical trial. So this study basically aimed to answer the question using electrical impedance tomography, or EIT. And I don't know if our listeners are familiar with EIT. I started to learn more about it for the past like 12 months. It's a fascinating tool where you have a non-invasive, basically bedside tool that can track changes in regional and global lung volume, including and expiratory lung volume, by measuring impedance across electrodes placed on the chest. So the kids wear like kind of a belt around their chest, and you get these sort of diagrams of lung volumes and aeration. It's quite interesting. So this was a randomized double crossover trial conducted at the Mater Mothers Hospital in Brisbane, Australia. Um, it's a small study. 16 preterm infants, all less than 36 weeks gestational age, were enrolled. They were all on high frequency oscillator, and they had to have their FiO2 between 25 and 70% to maintain SATs above 90. Major congenital lung or heart anomaly obviously were considered exclusion criteria. So they randomized these infants basically into two groups, some of them receiving high frequency oscillation with a sigh breath, some without. The sigh breaths were delivered 3 times per minute, so the rate was 3. Each sigh used an inspiratory time of 1 second and a PIP of about 30 centimeters of water. The sigh frequency was chosen to limit interference with CO2 clearance, maintaining the gas exchange strategy. The primary outcomes were change in end expiratory lung volume, ventilation distribution measured through the GI index, and secondary outcomes looked at the SATs, the heart rate, the blood pressure, and other ventilatory parameters. So the results are very interesting. The infants in the study had a median gestational age of about 25.5 weeks and a median birth weight of about 700 grams. Truly like small baby. So that was kind of helpful. So what the team found was that the addition of sigh breaths significantly increased global and expiratory lung volume. This increase was especially notable in the posterior or the dependent lung regions, and that was found to be statistically significant, and also in the left lung. Over time, the increase in global and expiratory lung volume, right and left, and the GI index improvement were all statistically significant. There was a trend toward increased impedance amplitude, suggesting possible tidal volume benefits as well. Now, from a physiologic standpoint, the oxygen saturation was significantly improved on the group that received sigh breaths. The mean airway pressure was not significantly altered. And if anything, MAP set points were actually lower in the group that received sigh breaths. The relationship between SATs and FiO2 showed no statistically significant improvement, but the overall direction seemed to be positive. There were no other significant changes in hemodynamic or ventilatory parameters between the two strategies. So in conclusion, the authors are saying that sigh breaths during high-frequency oscillation ventilation improves end expiratory lung volume, ventilation distribution, and short-term oxygenation, and that these findings are physiologically sound and clinically promising. However, the study is very short in terms of the number of babies that enrolled. It's not looking at long-term outcomes, and it's definitely not powered for neurodevelopmental outcomes. So we don't have the safety data on extended sigh breath usage and its effect on outcomes like BPD and ventilator days. And so that's why they're recommending obviously longer and larger trials. But I thought that was interesting. It's a topic. I mean, I saw the title and it reminded me, like you said, to our discussions in the unit. So yeah, definitely brought that back to the table.
Yeah. You could see how potentially over time that may be helpful, but yeah, we'd have to balance it with those, adverse events, things like that. Neat. Okay. You wanted to do another one or you want me to go?
Oh, you can go.
Okay. I actually have another study from India, which I'm just going to just do kind of briefly because I think it's of value, but their practice is very different than ours. So this is in the American Journal of Clinical Nutrition. It's called Effect of Kangaroo Mother Care in Low Birth Weight Infants on Human Milk Intake, a randomized control trial. So basically what they did is
Where was that published?
Where?
Yeah, which journal?
American Journal of Clinical Nutrition.
Okay.
Yeah. So the study participants were part of another primary trial, but they used this same, just like a sub-study to look at eligible babies in terms of kangaroo care. So basically, they took newborns weighing 1,500 to 2,250 grams and their mothers and screened them from enrollment within 72 hours of birth in the first trial. So in the sub-study, they were able to consent moms and their infants aged between days 3 and 7 after birth. So they have a group early on from 2015 to 2018, and then they even enrolled more babies from 2017 onward. So basically what they did is they had an intervention group and they had a control group. The Kangaroo Mother Care Intervention Group comprised of promotion and support of continuous skin-to-skin care and exclusive breastfeeding. So basically, the intervention delivery team would visit the infant mother dyads allocated to the intervention arm. And most of these visits were occurring in their homes, even in this cohort of babies, 1,500 grams to 2,250 grams. And so basically they were going and supporting kangaroo mother care with the dyad on days 1, 2, 3, 5, 7, 10, 14, 21, and 28 after birth to really just help them manage with this continuous skin-to-skin care. So they were counseled to practice skin-to-skin care for as long as possible during the day and the night, and they basically trained the other family members to help assist this mother. So they wanted to really look at the mean daily infant human milk intake, and they wanted to look at some other composition of breast milk markers, nutritional biomarkers. So this was kind of interesting. They used this I hope I'm saying it right, deuterium dilution dose to mother technique. So basically, the mom was given this measurable drink of deuterium at their homes. And then they basically were able to pull it from the saliva in the moms and the babies. So that's how they measured how much milk transfer. Okay. So they were using kind of this mean daily water transfer from mother to infant during a 14-day period. Okay, that's kind of where we are. So they had 550 eligible infants and their mothers were enrolled, and they wanted to look at milk assessment. So, among the 550 participants, infant human milk intake assessment was completed in 85% in the control arm and 86% in the intervention arm. The median age of enrollment was day 5 in both arms. The median infant weight at enrollment was 2.1 plus or minus 0.2 kilos. Baseline characteristics were similar across the arms. For the maternal factors, place of birth, like home births, was thought to potentially be a potential confounding factor. It was unequally distributed. So 18% in the control arm and 13% in the intervention arm delivered at home. In both study arms, 64% of the included infants were born preterm. There were no significant differences in the baseline characteristics of the infants when those data was available. So in the control arm, so not the intervention arm, asked to do skin-to-skin care, 8% of mothers reported practice of skin-to-skin care, and the mean duration of skin-to-skin practice was 2 plus or minus 7 days, with 0.5, so 30 minutes plus or minus 2 hours per day. In the intervention arm, all of the mothers reported practicing the use of skin-to-skin care. The mean duration of skin-to-skin practice was 28 plus or minus 2 days, with a mean duration of 12 plus or minus 4 hours a day. The mean human milk intake in infants over the 14-day period from enrollment was 331 plus or minus 144 in the control arm, and 368 plus or minus 135 grams per day in the intervention arm. So, compared with the control arm, the mean difference in infant human milk intake in the kangaroo mother care arm participants adjusted for place of delivery was 37 grams per day, or 12 grams per kilo per day. And on the basis of multiple analysis, the mean daily intake of human milk was 331 grams per day in the control arm, 370 grams per day in the intervention arm, yielding a mean difference of 38 grams. In the subgroup of infants born preterm, the adjusted mean difference in the human milk intake was 45 grams per day, compared with 20 grams per day in full-term infants. So the effect was greater in those babies born preterm. Among SGA infants, the adjusted mean difference in human milk intake was 40 grams per day, whereas in appropriate for gestational age infants, it was 31 grams per day. So again, a bigger effect in the SGA infants. The mean concentration of carbohydrates in human milk for mothers in the control arm was 50 plus or minus 6. In the intervention arm, it was 51.2 plus or minus 6. The mean difference was 1.2. The mean concentration of total protein in human milk was 16.3 plus or minus 4. And then the intervention arm was 15 plus or minus 2. The mean difference was minus 1.3. The concentration of fat was similar in the control arm and the intervention arm. They did not find any differences in the mean concentration of the human milk amino acids, IgA concentrations, and lactoferrin in the study arm. So I thought this was interesting because, well, it's a good reminder that in many places of the world, moms are doing 12 hours of skin-to-skin care a day. This could potentially improve milk output, and it had a bigger effect for preterm babies and SGA babies.
Mm-hmm.
Mm-hmm.
Now it's always sort of these types of studies where you're mostly not surprised, right? You're mostly not surprised, but
Yeah,
you're
that's
like,
fair.
yeah, but you're like, yeah, like sign me up.
Right.
But it's interesting also to see how other, like, I think that we all have resources constraints when it comes to resources, and leveraging these very cheap, low tech tools could definitely help you achieve outcomes that go beyond that. I think that's the interesting part.
Mm-hmm. For sure.
All right. we don't have a lot of time left. I'm going to do my my paper, and then not my paper, the paper that I've enjoyed reading the most this week, and then we'll see. I have another one, but if I have time. So this is a paper that I found in the Journal of Perinatology, and it's called "Interprofessional Perspective on Non-Invasive Respiratory Support Practices in Extremely Preterm Infants: A Canadian Survey." A lot of the team members I'm actually on good terms with, Dr. Mark Beltempo, Dr. Guillermo Santana. And so I was curious to read this paper just because they wrote it, but also because of the title. So um, we all know that non-invasive respiratory support is critical for us in the NICU, but while it helps us avoid intubation and its associated complications, its application is far from straightforward, and it demands bedside attention. You have to maintain it, you have to monitor, you have to troubleshoot. It's a lot of work, and failure of non-invasive respiratory support is not a small deal. You have both short and long-term morbidities that are associated. So the authors were asking the following question: can we better understand the barriers and the variability that is associated in practices related to non-invasive ventilation? And they did so by listening to the frontline workers, physicians, nurses, and respiratory therapists. So basically, what they did is that they sent this survey nationally to Canada. They identified 32 NICUs, so they sent it to their 32 NICU directors. They sent it to 13 fellowship director, to 32 nurses manager, to 32 respiratory therapist educator, who then circulated that survey with their teams. It had 19 items, 3 categories: the perspective of people on non-invasive respiratory support devices and management strategies, the monitoring and management, and the failure and improvement strategies possibly for non-invasive respiratory support. They were given like a clinical vignette to sort of put a context to all that, and sent the survey. So um, they got like 381 responses, 61 physicians, 173 nurses, 147 respiratory therapists. They represented about 23 tertiary NICUs across Canada, and 24% of the group had 0 to 5 years of experience, 22, 6 to 10. But most of the participants, 54%, had more than 10 years of experience. So, perspective on devices and strategy. So let's start with device exposure and usage. So CPAP was the most commonly used form of non-invasive respiratory support, reported by 69% of providers, typically usually at pressures of about up to 8 centimeters of water. NIMV was followed at 21%, and usually using peak pressures of about 20 centimeters of water, with an IQR of about 18 to 24. Now, what's interesting is that they asked how people felt about these pressures. They're like, is it high? How do you feel like you guys are using high pressures? And there were some interesting interprofessional differences there, that nurses were more likely to feel unsure or feel that CPAP and NIMV level were too high, especially when the pressures were 10 or higher, or that you reached 22 or more on NIMV. Now, so for interfaces, the dominant strategy reported by about 70% of groups was to alternate between the nasal mask and the nasal prongs. But notably, 130 respondents actually preferred a different interface that was typically used in their units. So I'm just going to pull up the rest of my notes here. So I thought that was interesting that there's not a great level of satisfaction with these interfaces strategy. Altogether, when it comes to the perceived difficulty of non-invasive respiratory support, 62% of physicians, 45% of nurses, and 45% of RTs found that the provision of non-respiratory support was challenging. So in terms of perspectives on monitoring and managing events, so across all provider groups, there was strong agreement that suboptimal positioning, airway obstruction, and poor interface fit contribute to respiratory events. But again, there were some interesting differences that came up. Nurses and RTs were more likely than physicians to view gastroesophageal reflux and anemia as important contributors to the respiratory instability. Documentation was another pain point. Around 20% felt that the apnea documentation by nurses were not often reliable, with similar concerns for desaturation and bradycardia entries. However, there was a near consensus on what constitutes a reportable event. 88% agreed that events requiring intervention, and 69% agreeing that those lasting more than 20 seconds should be clearly documented. So, a perspective on failures and solutions. When asked about reintubation, 57% perceived that their unit was highly tolerant to respiratory events before acting. And somehow this brought me back to a lot of awkward interactions sometimes. 39% noted that tolerance threshold vary widely depending on the physician on call. So again, something we've all encountered. Interestingly, 44% of physicians believe that 44% of physicians believed reintubation could often or always be prevented. But nurses, 29%, and RTs, 28%, shared that optimism. So not as much of a
44%.
pretty bad.
Always.
Yeah. As for preventive strategies, there was strong support for protocolizing practices related to non-invasive respiratory support, increasing nurses to patient ratio and RT to patient ratios, establishing clear criteria for reintubation supported by 88% of all respondents. Talking about the value of having in-house neonatologists, 33% of the doctors felt like this was helpful, but 57% of the nurses thought this was helpful. So clearly some bias happening there from the doctors. Yeah. On the topic of training, 17% rated their non-invasive respiratory support education as neutral or insufficient, and hands-on workshop were supported by 84% of physicians, 76% of nurses, and 63% of RTs. So this study just underscores how complex, I guess, this practice really is, even though we use it fairly commonly, and how collaborative really it needs to be. It's not just about the technology or the interface, it's about how we apply it, it's about who's at the bedside, it's about what kind of training we get, what kind of protocols we have in place. And so the authors really emphasize that we need better scientific evidence on the application, maintenance, and monitoring. We need interprofessional collaboration to understand behavioral and organizational influences, and standardized guideline and harmonized training to reduce variability. So it's a team-based approach, and this was definitely a good read.
Yeah, for sure. It's nice to see that, especially when lots of our different staff types and members are included in the evaluation. I had a really quick one, which will hopefully allow you to do your last one. This is in JAMA Pediatrics, about prenatal cannabis use and neonatal outcomes. Lead author Jamie Lowe, senior author Devin Kansagara. Basically, they wanted to see, is cannabis use in pregnancy associated with neonatal outcomes? This was a meta-analysis, and we don't like to do a lot of review papers like this, but even in their background, they basically said it's not ethical to conduct randomized clinical trials of prenatal cannabis use, given our concerns about its safety. So observational studies are basically the best thing that we have.
Where was that published, you said?
JAMA Pediatrics.
Sorry, thank you. Yeah.
Where did they get? They had they used 51 studies in 69 publications. This was 21 million.
Wow.
146,938 infants.
We're not used to these big numbers, I know.
No. So they had done this meta-analysis once, and then they're doing it a second time using 8 more studies since the original publication date, adding 1 million new participants. The other thing that was different about this study was they wanted to also look at, was there a dose response? So some of the studies provided information about dose response, and basically they extracted the heaviest users from those studies. So for instance, they say if a study reported outcomes for cannabis monthly or less, weekly or daily, then that daily use group was included in the heavy use group. Okay.
Mm-hmm.
So, um, they found 24 studies analyzing this association between prenatal cannabis use and low birth weight infants. And in their meta-analysis, they found an increased odds of low birth weight infants in those with prenatal cannabis use, an odds ratio of 1.75. And in their dose response, they found that in those with heavy cannabis use, the odds of low birth weight increased to an odds ratio of 2.36. Um, certainty of evidence is moderate. So then they looked at prenatal cannabis use in preterm birth. The odds of preterm birth were increased for those using cannabis in pregnancy, an odds ratio of 1.52. And for those with heavy use, higher odds, a combined odds ratio of 1.95. Certainty of evidence is moderate. Then they wanted to look at perinatal mortality. So they found an increased odds of perinatal mortality with cannabis use, an odds ratio of 1.29. And there were 3 studies with that had this specification about heavy use, but they actually found that the odds were no longer statistically significant in this 3 studies of that included heavy use. They found 21 studies that looked at cannabis use and small for gestational age. And the odds of SGA increased with prenatal cannabis exposure, an odds ratio of 1.57. And for those with heavy use, an odds ratio of 1.63. Certainty of evidence moderate. So I was hoping there would actually be more perinatal outcomes, but these are the biggies. I think that we are seeing more and more marijuana use. So I always like to take a look at the marijuana papers when they come in.
For sure. I think that, yeah, I mean, I haven't gotten off my initial sort of stance on this. It's not because legalization doesn't mean beneficial. I mean, I think that because it's that you have more access to something, it doesn't mean that it's good for you. And we kind of know the effects of marijuana, unfortunately, and the legalization doesn't change that. Just have to be careful.
Yeah, agreed. Agreed. Yeah. I mean, it's like so many other things,
Yeah,
alcohol, cigarettes.
alcohol,
Yeah.
cigarettes, absolutely, exactly. Yeah, yeah.
So,
Or even illegal drugs. I mean,
sure.
yeah, the political context doesn't change the substance itself. The substance is what it is. Um, I don't. I mean, we're close to the end. I'm not gonna extend this journal club too much, but there was an article that came out in the Archives of Disease in Childhood that caught my eye, and it was less impactful than I thought. But I mean, now you'll see why. It's called Near Infrared Spectroscopy During Respiratory Support at Birth: A Systematic Review. And this is first author is Vix Monelli, and it's coming from the ILCOR, from the International Liaison Committee on Resuscitation Neonatal Life Support Task Force. So obviously a big group publishing on a potentially maybe an innovative approach to management in the delivery room. And obviously they're talking about perinatal transition and compromised cerebral oxygenation that may lead to morbidity, mortality. And the question really is, should we start using NIRS in the delivery room to sort of guide respiratory management? Now, there are some issues obviously with the potential randomization. So this is just a systematic review and meta-analysis based on Ovid Medline, Embase, and Cochrane Central. So they looked at newborn infants of all gestation. They were looking at studies that looked at any newborn receiving CPAP or NIMV during resuscitation. They looked at the intervention from studies that would look at CRSO2, like cerebral regional saturation, with dedicated treatment guideline. And they were looking at outcomes that involved survival without neurodevelopmental impairment, survival alone, severe IVH, PVL, etc. Now, they reviewed like close to 600 articles, and they only found 3 articles reporting the outcomes from 2 randomized trials. And what they're saying is that no data was found for survival without neurodevelopmental impairment. And so they could not exclude benefit or harm from delivery room monitoring of cerebral regional saturation for survival, for severe IVH, for PVL, and cerebral regional saturation below the 10th percentile. And so this paper basically just highlights that the limited evidence can't really exclude neither benefit nor harm. So, I mean, if you want to read the paper, you're more than more than welcome to. But I thought, like, is this the paper that's going to lead to like a revision of our approach to resuscitation? But the data is just not there yet, so not much to add. You're muted. No
I'm
thoughts.
here.
We had.
Too bad.
By the way,
Too
since it's
bad.
the end of the episode, like, we've had a very long day.
The longest day we've had in a very long time.
All right. It was, yeah.
But should I do one more? Should I do my last paper?
Please, yeah. Don't
Okay.
let me obstruct.
And then we can be done. Oh, we're still not done with our long day after this.
No, we're not.
No. Okay. I'm going to try to review this quickly. I'm not very good about that, but this is in Journal of Perinatology. This is coming to us from our colleagues in Japan, and it's entitled Neurodevelopmental Outcomes at Age 3 Years of Preterm Infants Born at 22 to 31 Weeks Gestation.
You're not taking the smallest of papers.
I'm not taking the smallest, but I didn't want it to linger. I think people are always wondering, and the paper came out, and I just wanted to make sure we do it. So they were looking at infants born before 32 weeks, and they were actually looking at this group from 2012 to 2014. So this is almost a decade ago, okay? From their improvement of NICU practices and team approach cluster trial. This was the INTACT trial. And they were looking for survival without moderate or severe neurodevelopmental impairment. So basically, the INTACT trial was like this quality improvement program in Japan that didn't have the effect that they had hoped it would in changing outcomes for babies who were enrolled in this kind of package of interventions. But they are just now reporting on the neurodevelopmental follow-up. So they had 40 NICUs that were allocated to the intervention. Initially were 19 NICUs and 21 control in NICUs. They had, then this is for the initial study, the INTACT trial. I'm actually going to skip telling you any more about the original trial. I'm going to just tell you about the current trial. We're running short of time, and you want to know about the long-term outcomes, okay? So this was a secondary analysis. They combined then both the intervention and control groups to get this cohort. So outcomes, they wanted to look at infant survival at age 3. And this is how they defined disability. So moderate neurodevelopmental impairment was defined as neurologic disability with one or more of the following conditions: cerebral palsy with a GMFCS level of 2. They use the Kyoto scale of psychological development test. So less than 70. Visual impairment requiring correction, but not been fully corrected. Some other things about vision here. And I wanted to tell you, so this developmental quotient less than 70 is basically equivalent to a Bailey 3 score less than 85. So pretty.
Yeah, it feels more like a Bailey 2 almost, where they get this sort of this one single score that, right?
Yeah.
On the Bailey 3, you would have subcategories. You could break that down. Yeah. It feels almost like this MDI that you used to have on the Bailey 2.
Perfect. And then severe NDI included cerebral palsy with a GMFCS level 3 to 4, and this Kyoto score less than 55, blindness or the ability to perceive light only, impaired hearing that's not correctable. And then any individual residing in a facility for children with severe physical disabilities was considered to have severe neurodevelopmental impairment. So then they have these beautiful tables by week of gestational age. Which we will get to in just a second. They had 2,722 evaluated at NICU discharge. And then they had a total, let's just say, 2,360 infants, which were 90% of the survivors that were able to attend the follow-up visit and were included in the analysis of the outcomes. So for the group, I wanted to tell you there are 43 22-weekers, there are 152 23-weekers, there are 197 24-weekers, 220 25-weekers, 280 26-weekers, 350 27-weekers, 370 28-weekers, 400 29-weekers, almost 400 30-weekers, and 284 31-weekers. So we can talk a little bit about the clinical characteristics and morbidities. A higher percentage of SGA infants, so a birth weight below the 10th percentile, was observed with increasing gestational age. Interestingly, antenatal steroids were observed for 44% at 22 weeks and greater than 60% at the other weeks. So most of the 22-weekers still didn't get antenatal corticosteroids. A higher incidence of chronic lung disease requiring continued oxygen use and respiratory support at 36 weeks, IVH, sepsis, and NEC was noted with decreasing gestational age. The incidence of PVL was the highest at 24 weeks gestation, only 5%, followed by 4% at 23 weeks and 3.5% at 28 weeks. The overall NICU mortality rate was 3.5% for all infants. The mortality rate decreased with increasing gestational age, ranging from 28% at 22 weeks to
Let that sink in for a second, huh?
Yeah. Yeah. 28% at 22 weeks, 0.4% for those at the 31-week gestation mark. So that was death. And then they did neurodevelopmental outcomes at age 3. And then they do the composite outcome, which was basically they wanted to see survival without moderate or severe neurodevelopmental impairment. So for the neurodevelopmental outcomes, like I said, there's a lot of information here, but a higher percentage of SGA children was observed with increasing gestational age, which was interesting, 0% in the 22-weekers and 56% at 31 weeks gestation. Infants with cerebral palsy of GMFCS level 2 to 4 was 4.7% and was highest in the infants born at 23 weeks gestation, 10% of infants in the 23 weeks. All infants born at 22 weeks gestation with cerebral palsy, this was 10% of infants, had higher levels of cerebral palsy. So GMFCS greater than or equal to level 3. Mm-hmm. The percentage of children with cognitive delay decreased over gestational age. So 54.8% for those born at 22 weeks to 10.8% for those born at 30 weeks. Additionally, the proportion of children with severe cognitive delay correlated again with gestational age. But the proportion of children with this borderline cognitive level was similar in children born at 22 to 27 weeks gestation. 12.9% of children born at 22 weeks and 24% of those at 23 weeks had what was considered, quote, normal cognitive development. 2 infants born at 25 and 29 weeks had blindness or light perception only. The percentage of visual impairment requiring slight correction but not fully corrected was 2%. 2 infants born at 26 and 27 weeks had severe hearing impairment that was not correctable. And then among the infants with the full evaluation, 13% had moderate neurodevelopmental impairment and 7.8% had severe neurodevelopmental impairment. The survival without moderate or severe neurodevelopmental impairment for the whole group was 79%. But this was higher, obviously, in the higher gestational ages. So survival without moderate to severe neurodevelopmental impairment was 45% at 22 weeks, 57% at 23 weeks, and 88% at 31 weeks.
Yeah, but those numbers at 22 weeks were quite low in terms of the census that they had, huh?
Yeah. So basically, they had 31. I told you they had 31 surviving infants at 22 weeks. The babies with no cerebral palsy was 87%, but all the babies who had cerebral palsy, this 10%, almost all of them had severe cerebral palsy. 3% had mild, 10% had severe, and 87% had no cerebral palsy. Out of the 22 weekers, 12.9% had no cognitive delay. This 32% in this kind of borderline cognitive delay. So they didn't classify as moderate to severe neurodevelopmental disability. That's where the big number comes from. 12.9 plus 32.3 is about 45%. 32.3 were delayed and 22.6 severely delayed. Mm-hmm. So that's where the numbers really come from for the kind of composite outcomes. But I thought it was interesting. They have these nice graphs that look at, by gestational 8-week of life, looking at survival, moderate and severe neurodevelopmental impairment. So that's where they are. And again, these were from a cohort almost a decade ago. So they've been doing the 22-week thing longer than most centers in the States.
Yeah.
So I'd love to see an updated cohort. But I think these outcomes are consistent with our, say, United States cohort, potentially better than our United States cohort.
It's it's an interesting story, because we've always been very interested by what the Japanese have been doing. Because we know they have good outcomes. And so we've been following that closely. So for the first edition of Delphi, we wanted to take that opportunity to bring someone from Japan to talk to us, and we were able to. Dr. Namba from Japan came and gave a presentation on what is the approach to babies on the edges of viability. It cost us a fortune, as you can imagine. We were a small conference.
The whole budget.
It's so funny but that was important, and the video is now on YouTube, and it's been quite popular. I guess not popular. Popular is the wrong word, but like people have watched it. It's important to share that. And so what's great about it is that we've been able to engage with this community and talk to them about their protocols and their guidelines and so on. So,
and he does provide from their institution their outcome data during that talk. So definitely for people to take a look.
Yeah. And one of the things that he's mentioned is that he has said that their outcomes are phenomenal for survival, right? He was saying like, and they have a very interesting approach. So they mentioned how survival, they do phenomenal. But in his presentation, they were saying the next frontier for us is going to be survival plus free of neurodevelopmental impairment. So it's not surprising to see those numbers. And it's important, I guess, for people to understand that they are a little bit ahead of us in the sense that they're doing very, very well when it comes to survival. And now they're going to start modifying their protocol so that they can optimize for neurodevelopmental outcomes. So it's very interesting. But we do have to take everything with a grain of salt, just because, again, I don't know the Kyoto developmental scale. Like I don't know if that translates 1-to-1 with a Bailey, but again, some other things are a bit more objective, like the CP diagnosis that is fairly like similar in terms of how we diagnose that. So there's still some differences, but the Japanese, I think it's kind of nice when you're able to sort of blaze to put a trail of like and in a style. I know that we have the Scandinavian approach, we have the Japanese approach, and so I'm always interested in seeing what are the tenets of these different methods.
All right, buddy.
All right, do you have one more?
No. I'm done.
You're done. Okay, well, thank you very much. This was a great journal club, and we will see you all next time.
Bye, buddy.
Bye.